So we are going to go ahead and get started. Good afternoon, everyone. My name is Elizabeth Aloni with Schneps Media, and I'm thrilled to be able to provide updates in heart failure management. Just to tell you a little bit about who Schneps Media is, we are the largest local media company in the New York metro area. We publish over 80 newspapers, magazines, websites, webinars, podcasts, and events throughout Queens, Bronx, Brooklyn, Manhattan, Staten Island, Westchester, Long Island, the East End, Philadelphia, and now Palm Beach, Florida. And today we are thrilled that you are joining us for this update in heart failure management with world-class doctors from Columbia, Weill, Cornell, and New-York-Presbyterian. Dr. Uriel will be interviewing the illustrious panel. So before I turn it over to him, please let me introduce the panel to you. First, I'm thrilled to introduce Uriel, MD, MSc, FACC. He's the director of the New-York-Presbyterian Heart Failure, Heart Transplant, and Mechanical Circulatory Support Programs. He received his medical diploma from Ben Gurion University in Israel. After serving for 5 years as a physician in the Israeli Defense Forces, he completed his internal medicine residency and cardiology fellowship at Haythe Medical Center, affiliated with Tel Aviv University. Dr. Uriel completed his advanced heart failure training at Columbia University Irving Medical Center, where he stayed on as an attending physician until 2014 while earning his MS in patient-oriented research at the Mailman School of Public Health. In 2014, he was promoted to the Lewis Block Professor of Medicine and the Director of Heart Failure, Heart Transplant, and Mechanical Circulatory Support at the University of Chicago before returning to New-York-Presbyterian in 2019. Dr. Uriel is a world-renowned heart failure cardiologist and a dedicated researcher with more than 350 peer-reviewed papers and numerous book chapters in the field. Under Dr. Uriel's leadership, the New York-Presbyterian Heart Failure, Mechanical Circulatory Support, and Heart Transplant Program have united into the biggest heart failure program in the country, internationally renowned for its elite clinical outcomes and prolific academic activity. Dr. Uriel is leading the heart failure digital health transformation, bringing artificial intelligence and machine learning into everyday practice, expanding equitable care across the greater New York City area. Welcome, Dr. Uriel.
Thank you. Thank you very, very much.
And yes, please.
No, please.
I would love to introduce the rest of the panel, and then I'm turning it over to you, the tremendous expert. So next, I would like to introduce Jennifer Haythe, MD, Associate Professor of Medicine, Associate Director, Adult Pulmonary Hypertension Program for Advanced Cardiac Care, Columbia University, Irving Medical Center, New York-Presbyterian Hospital. Dr. Haythe graduated from Harvard University in 1995. She completed her medical school and residency training at Columbia University of Physicians and Surgeons in 2003. After finishing a congestive heart failure cardiac transplant fellowship at Columbia in 2005, she went on to complete her fellowship training in cardiovascular diseases there in 2009. She is currently an associate professor of medicine in the Division of Cardiology, Center of Advanced Cardiac Care at Columbia, Director Cardio-Obstetrics Program, and the Associate Director of the Adult Pulmonary Hypertension Program. Dr. Haythe specializes in pulmonary hypertension, heart failure, and cardiac transplant. She has a special interest in the care of pregnant women with cardiovascular diseases. Welcome, Dr. Haythe. Next, I'm thrilled to introduce Dr. Kevin Clerkin. He's an associate professor of medicine specializing in the diagnosis and treatment of patients with advanced heart failure. His practice includes those requiring left ventricular assist device or heart transplantation. He's board certified in internal medicine, cardiovascular disease, and echocardiography. Dr. Clerkin received his medical degree from Albert Einstein College of Medicine, where he was inducted into the Alpha Omega Alpha Honor Society. He completed his internship in residency in internal medicine and completed his cardiology and heart failure fellowships at New York-Presbyterian Columbia University Medical Center. He also received a Master of Science degree in patient-oriented research, biostatistics from the Columbia University Mailman School of Public Health. Dr. Clerkin is an NIH-funded clinical investigator, and his research focuses on improving the quality of life and survival in heart transplant recipients. He's published more than 60 peer-reviewed manuscripts, reviews, abstracts, and book chapters. Welcome, Dr. Clerkin. And And next, I'm thrilled to introduce Dr. Maria Karras. She's an assistant professor of medicine at Weill Cornell Medicine. After receiving her medical degree from Weill Cornell Medical College, Dr. Karras completed her training in cardiology and advanced heart failure in NewYork-Presbyterian Weill Cornell. She serves as the medical director of the Cardiac Intensive Care Unit and leads the Cardiogenic Shock Team at NewYork-Presbyterian Weill Cornell. Her research interests include cardiogenic shock, mechanical circulatory support, and pulmonary hypertension. Welcome, Dr. Karras. And now I'm thrilled to introduce you to Reema Bhatt, MD. She is an attending cardiologist at NewYork-Presbyterian Queens and an assistant professor of clinical medicine at Weill Cornell Medicine. Dr. Bhatt completed her fellowship in cardiovascular disease at Rush University Medical Center and her fellowship in advanced heart failure and transplant cardiology at Weill Cornell Medical Center. She specializes in the diagnosis and treatment of patients with advanced heart failure, heart transplant, and pulmonary hypertension. She's a special interest in the care of heart failure patients using remote monitoring technologies. We are so fortunate to have this team. I'm a little fangirl right now. I'm like, wow, incredible. So we are so lucky to have this panel with us today. I'm going to turn it over to Dr. Uriel, who will lead the discussion.
Elizabeth, thank you very much. Actually, we are thrilled to be here because it's a special month. It's hot month this month, February. And it's a month that a lot of things is just let us reflect a little bit how important is our heart health in general. And when we're speaking now, and we're speaking to a lot of physician and provider in the field of cardiovascular disease, we need to ask ourselves, when do we actually, even though we are providing in cardiovascular disease, we need to send a patient to see a heart failure specialist. So maybe I will start with Dr. Haythe, and Dr. Haythe, maybe you can tell us what kind of patient you see in your practice that actually coming from other cardiologists, other maybe internal medicine doctors, and in general.
Yeah, thanks so much, Dr. Uriel. So we have a range of patients coming at different stages of heart failure. I think it works best when there's a really nice collaboration with the referring cardiologist. So usually we're looking for patients who have a diagnosis of heart failure, have been on guideline-directed medical therapy, usually started by their cardiologist, but they're starting to have some issues with that. Either they're not tolerating their medicines anymore, they're having to cut back on the doses, their functional class has worsened, their doctor recognizes that this patient needs to be considered for an LVAD or a transplant because of their worsening functional status. Maybe even just a general cardiologist who has a very busy practice and there's a lot of small details. They need to get genetic testing for the patient. They want the patient to get a cardiopulmonary stress test. The patient may need an upgrade to a BIV ICD. So these are all things that come into play when patients are referred to us. Obviously, the earlier the better, even if it just means we check in, see how they're doing, and then they continue to be followed locally until they need more advanced care.
Thank you. So maybe we'll speak about this advanced care a little bit more. And Dr. Karras, maybe you can help us and even maybe explain to us, who are the patient exactly that we don't want to be late, that we're afraid that they need advanced heart failure care, and that's the reason they definitely need to see a heart failure specialist. Dr. Karras?
Yeah, thanks, Dr. Uriel. So I think what is exciting in 2021 is that we actually have a lot of different things to offer patients with advanced heart failure. But many of these things, whether it is something called like a left ventricular assist device or a heart transplant or the ability to participate in a new exciting clinical trial, oftentimes patients need to be caught a little bit earlier on in the process to be good candidates for these therapies, which actually can offer long-term survival and good quality of life. So some of the warning signs that may indicate that your patient may be progressing into the next stage of heart failure are frequent hospitalizations for heart failure, needing intravenous medications when they're in the hospital, either intravenous diuretics or sometimes the need for intravenous inotropes like dobutamine or milrinone. When you're following your patient in the office, usually we'll be checking blood work. So if you start noticing that your patient's kidney function is starting to get a little bit worse, or their liver function tests are not quite normal, these might be indicators that the heart is having trouble now pumping blood to the rest of the body. And so when we see these small changes, this can indicate to us that we might need to start thinking about the next steps earlier on. For patients who have defibrillators, if they are having a lot of arrhythmias on their interrogations or they're being shocked for arrhythmias appropriately, that's another indicator that we need to start thinking about sending them for the next type of evaluation.
Mm-hmm. And maybe Dr. Clerkin, we're speaking that we have a lot of advanced options, as Dr. Karas just told us. How good are they? How good those patients? What's going to be their quality of life? How long they're going to live in the different type of therapies that we have?
It's a great question, and really what our patients want to know when we start talking about them. The two main advanced therapies that we talk about are, as Maria mentioned, are LVADs or mechanical heart pumps. With the newest generation, the HeartMate 3, showing excellent outcomes. In the previous generation of the device, you could say the 5-year outcomes were about 50%, but with the newest generation, we've seen the outcomes have actually approached those of transplant with nearly 85% surviving at 1 year, and seemingly going to be much better than that 50%. And then what most of us still view as the gold standard, despite LVADs nipping at the heels, is heart transplant, where patients have a median survival these days of about 14 years post-transplant, with 1 year survival internationally ranged about 90%, and varying between centers. For instance, last year, our 1 year patient survival was 97%. So you really can have fantastic outcomes, short-term and long-term, for these patients to give them meaningful extension of their life, but also a significant improvement in their quality of life.
Mm-hmm. I understand. So we have those patients that definitely we want to see, and they need advanced heart failure therapy, and we can offer it to them. But the majority of heart failure patients actually doesn't need advanced heart failure therapy. And so, Dr. Bhatt, maybe you can help us understand a little bit what kind of other technology we can offer to patients if they come into your practice, and maybe how can we follow those patients when they're at home?
Sure. So we know that heart failure patients can be very difficult to manage and can be very cumbersome to manage: multiple hospital admissions, multiple medications, decompensations. And so as heart failure docs, we want to be able to help the community physicians, the primary care doctors, the primary cardiologists with these acute issues. And that's really where a multidisciplinary heart failure practice can really be of help. We certainly can offer a number of therapies, both on the outpatient side and the inpatient side, to really help optimize patients better, to help improve their quality of life. Some of these things might be as simple as allowing for IV diuretics on the outpatient side to really help stabilize mild but acute exacerbations. We also have ways to really keep patients at home and manage patients from the comfort of their own home through remote monitoring technologies. And we have a number of new devices that really have come into play, one of them being the CardioMEMS pulmonary artery PA pressure sensor. And really it allows for continuous pulmonary pressure measurements and allows us to titrate medications and diuretics appropriately to really avoid hospitalizations and symptomatic exacerbations for patients. And we know that this helps keep patients out of the hospital. We know it helps to improve mortality and quality of life. And so it certainly is and can be a really good option for our patients with both heart failure with reduced ejection fraction and preserved ejection fraction. In addition to CardioMEMS, I mean, there are a number of other things that we can offer, including more aggressive medical therapy titration. We know that patients do best when they're on optimal doses of guideline-directed medical therapy, and we certainly can help with that.
Definitely. And I have a question, because now we are going to put those technology into patient. Dr. Bhatt, is all the physician that is on this call and sending us the patients, they will need to follow them, or actually there is a centralized body that can help overseeing and help remotely monitoring those patients?
Yeah, we have a unique program called the Centralized Heart Failure Management Program here at NewYork-Presbyterian, and it's essentially a centralized hub for monitoring and management of all of our heart failure patients with remote monitoring technologies, including CardioMEMS, Philips remote monitoring, which includes blood pressure, pulse oximetry, and heart rate monitoring, as well as patients with HeartLogic device capable ICDs. And it's run by a group of heart failure physicians as well as heart failure trained physician's assistants that are trained in monitoring this data and looking for exacerbations and really treating these exacerbations when identified. And so what we've seen is that patients really appreciate the extra help. It certainly helps keeps patients out of the hospital, and it really relieves the burden off the primary cardiologist team to have to continuously monitor these patients at home.
Yeah, and I think this is really the future. The future is definitely going to have this tight collaboration with someone that, because we cannot monitor all those amount of data that they receive on a daily basis. We need to get someone help. But you know, I want to take now a little bit of a break and go deep into some very specific patient population. And maybe Dr. Haythe, maybe you can help us, because there is a patient population that when I get a call, I get scared. And this is the pregnant woman. And let's speak a little bit about heart failure in pregnancy. What do we need to know? What do we need to do? And who do we need to call? Because this is always stressful.
Well, you can always call me. I'm happy to help. And I know it is stressful because you're taking care of 2, maybe 3, maybe 4 lives instead of just one life. Every life is important. So we do our best to take care of these complicated and very anxious patients. I think that one thing that's unique about our program is we've been doing this for a long time. We have an incredible multidisciplinary team that is always meeting every week to discuss our high-risk cases. That involves the high-risk maternal fetal medicine group, cardiology, anesthesia, social work, nurse practitioners. So everyone involved with the care of pregnant women is at these meetings. And if needed, we can have the pediatric ICU team or the neonatal ICU team be available as well. So pregnant women are complicated because a lot of their symptoms can mimic cardiac disease, even if their pregnancy is going smoothly. So shortness of breath, swelling, heart murmurs, these are all things that we see in pregnant women, but is actually can also be something we see in heart disease. We know that the maternal mortality rate in this country is increasing, and it's one of very few industrialized nations with a rising maternal mortality rate. Cardiovascular disease is now the #1 cause of maternal mortality in this country. And so hypertensive disorders of pregnancy, peripartum and other cardiomyopathies, arrhythmias, valve disease, these things can all be addressed. What we've learned is that early understanding of their disease really helps their outcomes do well. We actually looked at all of our patients that we've taken care of in the last 10 years and found our readmission rates to be very low, probably driven by the fact that we were aware of these patients, that we followed them closely. And I like to say we're like catchers in baseball. We want to have everything ready so we can catch the ball when it comes. And this is true of pregnant women too. Being prepared is the most important thing. We don't like surprises. So if it's heart failure, we can put them in the ICU right away. We manage them with medications before and after. We can have ECMO ready if there's somebody who we're very worried about who has very high risk disease. We can just monitor them closely on telemetry, but whatever it is that they need, we give it to them, we provide it for them, and then we can deal with any emergencies that come up. And what we found is that when we do that and we follow these people very closely at discharge, also a very crucial time because the majority of women who die in pregnancy die after delivery, that those women do much, much better when they have close follow-up. So we are happy to provide you here with cardio-obstetric care and follow-up. And then if desired by the referring cardiologist, we can reassimilate, put them back with their referring doctor after the pregnancy. And with every subsequent pregnancy, you can be referred to us to manage and then go back to your local provider.
So there is no doubt that pregnancy and heart failure and heart disease in general is, of course, very scary. But Dr. Haythe, it's not only women in pregnancy that we sometimes miss the diagnosis. It's women in general in heart failure. There was a fascinating article that showed that women in heart failure actually diagnosed in almost 8 months delay compared with men with heart failure. Why do we miss this? And what can we do in order to have better management of women in heart failure?
So we know that in general, women have been underdiagnosed, undertreated, and understudied in cardiovascular diseases. And a lot of this came about in a pretty well-intentioned way, I'd like to say, where there was a crisis known as the thalidomide crisis back in the 60s, where a new drug was used in pregnant women and caused really bad birth defects. So for many, many years, the FDA prevented women from being involved in clinical trials when these women were of childbearing age. And it led to this real absence of studying women in cardiovascular disease. And so many of our studies really looked predominantly at men. And now there's a much more awareness. I think in general, we think of heart disease as a man's disease. I think many women, when asked about their family history of heart disease or other women in their life who've had heart disease, they won't know anybody who has it, even though it is the #1 cause of death for women too. So we have been on a huge education campaign, and this is true for heart failure as well. Letting people know it's okay to talk about, that women need to understand it's their #1 cause of death, that there needs to be earlier diagnosis and identification, and then treatment aggressively and research at the same time to make sure that these women are included in studies so that we know how well the drugs work, whether that they benefit from a BIV or not. Do they benefit from cardioversion? Should they have an LVAD put in? What is the delay for that? And so I think with more awareness, especially at our group, I think has been very proactive in trying to diagnose and care for women in general, that we will hopefully have improved outcomes in women overall in the next few years.
No, and I have to say that this field is growing and it deserves the expertise that you're bringing definitely to the table. And I wanted to use this field, even though it's sometimes intertwined in another field, cardio-oncology, but women that we know that one of the most common cancer is breast cancer, receive a lot of time adriamycin into it. When do you want to see those women? In what kind of involvement you want to be in their care? Because we know that they have one battle to fight is the breast cancer, and then they fight in heart failure from the adriamycin.
Right. Yeah, women actually have a bunch of different kinds of disease that a lot of men can't have or don't have. So we know for one, like you said, treatment for breast cancer with adriamycin is toxic. We also know that women are more likely to have autoimmune diseases that lead to cardiovascular disease and heart failure syndromes. Women are also more likely to have stress cardiomyopathy or Takotsubo cardiomyopathy than men. So all of, understanding all these risks. So we want to see women who have who have been diagnosed with breast cancer as soon as possible. We want to get baseline studies for them. We have an incredibly robust cardio-oncology program here. We get baseline echo, we can do MRI, we can even do a baseline stress test to see what their functional capacity is. And then we're following these people over time to make sure that we don't see a deterioration, that if there is a deterioration that starts to happen that appears to be dose dependent, or that they're on a medication where they potentially have a reversible cardiotoxicity, that drug can be stopped and we can monitor them closely. But if they present to us at any point in their history of cancer and their heart failure has progressed and is severe, those are women we want to advocate for to get LVAD and transplant as soon as possible if needed.
Thank you. So Dr. Kuras, maybe now we speak a little bit about women, but there is something that's common for both. Women and men come into the hospital sometimes in extremis, in a shock situation. So how do we identify those patients with the shock situation? When do we call? And tell us what are the tools that actually a center that is a tertiary center of advanced heart failure can treat those people that come in with shock?
Sure. So I think, this is sometimes one of the most challenging things that we're faced with in the hospital. Oftentimes when patients are very sick, they may not come with that sign that says what type of shock they have. So, the approach that we and other groups across the country have taken is that we try to identify patients who are exhibiting signs of end organ dysfunction, patients with low blood pressure, because now there is widespread use of ultrasound in many emergency departments and in ICUs in the hospital. it's very easy to be able to take a quick peek at the heart and look to see what does the heart function look like and get a little bit of a broader picture of what might be driving this patient's critical illness. We at New York-Presbyterian have taken the approach of a shock team, and this is a multidisciplinary team which brings together many different specialties. I think one thing I've learned and my colleagues have learned is that it takes a village to take care of these sick patients. And so we have brought together heart failure specialists, interventional cardiologists, cardiac surgeons, critical care anesthesiologists, and pulmonary specialists to evaluate patients in a timely fashion, and then come together as a group to figure out what is the next steps that these patients need. We've now been utilizing our communication systems through the hospital to be able to have an easy way, a single approach that then sends out a message to everyone simultaneously so that we're able to do bedside assessment in a timely fashion and to come together as a group, whether that is in person or on a telephone call. Then in terms of what we can offer, this is where actually working with also our partners in the community is really important. So here at the tertiary centers, we have a full toolkit of different devices that we can use for patients who truly need circulatory support. So it can be as simple as a balloon pump, but we do have miniature ventricular assist devices that can be placed through blood vessels percutaneously. These are known as the Impella devices, and these can actually support both the left and right sides of the heart. And then also these devices come in different sizes. And so depending on what level of support or what duration of time you think the patient's going to need, you may choose a different device for that patient. In addition, we do have access to ECMO, which is essentially a miniaturized version of cardiopulmonary support, like what you would use in the OR for someone undergoing a bypass or valve surgery. And this can be placed at the bedside even if needed in a patient who is crashing in front of you. So this obviously takes collaboration with all the different physicians. And what we now have branched out is being able to offer our services also at other hospitals in the region. And one way to do that is you can actually call the transfer center at New-York-Presbyterian if you have a very sick patient. The number is very easy, 1-800-NYP-STAT. And what we have trained all of our nurses in our transfer center is to be able to connect you directly to 24/7 to an on-call heart failure provider and loop in these other specialists to help decide, how we can best help your patient, whether that is sometimes us actually coming to you and helping the patient there to bring them back to the center where we can offer different therapies, or transporting them to the tertiary center and providing them with a type of mechanical circulatory support that's appropriate for the patient.
And Dr. Karas, now when the patient is going on those acute support or coming with a cardiogenic shock, how many of them we succeed in saving? What are the type of patient that we succeed in saving? And
I think, it's a tough question, Dr. Uriel, because it sort of depends on what the underlying cause is. So obviously one of the most common things that patients come into the hospital with is a myocardial infarction or a heart attack. And those patients, we know we have something to address the underlying problem. So patient comes in, we're able, for instance, to put a stent in their heart artery that's blocked. The heart may be very stunned in that scenario, but those patients oftentimes will get better. They might require the temporary support of one of these devices I just mentioned, but their survival can be very high if caught in a timely fashion. Other things that, I think it can be easily reversible is sometimes we have patients who have myocarditis. So viral infections or other inflammatory conditions, sometimes we can treat those underlying problems and support the patient through that treatment. But obviously, for some people, they aren't getting better on the devices. And this is where then we come together as a team to figure out, can they be a candidate for one of the more durable solutions that Dr. Clerkin was mentioning, like a left ventricular assist device or a heart transplant.
So Dr. Clerkin, we spoke a little bit about the outcome, and you spoke and said, wow, 97% 1 year survival in transplant, 50% will live 14 years. LVAD with 85% 1 year survival. We don't yet know the long term because it's a new device, the heart meets free. But how do they live? Is it a good life?
Yes. You know, we often will say to patients that the goal of either therapy is for the therapy to be forgettable. And when I say this to patients before, when we're discussing these, they often laugh. And at that point, it's not even really in their mind that they could forget about their heart failure, and that it's just something. And 6 months later, a year later, they'll often comment, you were right, and that's what's happening. Aside from, yes, I have to remember to take my medicines, or yes, I have to remember to change my battery. But besides that, I'm back to living. And so both these therapies, each in their individual way, get you back to living the life that people want to live, giving them that quality of life, and not just the quantity, to really be able to do what their goals are, to be with their family, their friends, travel. One of our patients was swimming, who had heart transplant, was swimming across the Long Island Sound last year. So they really can do fantastically well, and it's an amazing thing to get to see and take care of these patients, afterwards, to really see them realize that benefit.
Yesterday, Dr. Clerkin and the rest of the panel, probably each one of us can remember stories. Yesterday, in the transplant clinic, I saw someone that was transplanted 34 years ago. And she's working, and she's so passionate. And her mother came with her to the visit, and somehow we talk about what is the meaning of life. Because let's be honest, heart failure, it's the oncology of rest of medicine. And we can give someone 34 years. And the mother said, I want to say something, that actually when the physician told me that my daughter will need a transplant, I didn't want it for her, because I was afraid that she will have a terrible life, she will not have friends, that she will not be able to do what other people can do. And I think it's important to mention every life is different. And when we have a rope and it's have a tear suddenly and we tighten it again, it can be still a rope, but it will be different. But still, it's going to be a very meaningful life, a meaningful life on LVAD, a meaningful life in transplant. And I think what you're saying here is so important, because the referral, the physician here that listening to us, is actually the one that meets the patient the first time. Their impression of what those therapy is actually going to, a lot of time, will make the patient believe this is a real option for him or not. So I really want us to take a pause here, and maybe each one, and Dr. Bhatt or Dr. Haythe or Dr. Karas or Dr. Clerkin, just tell us what for you was like when you saw a first patient that a heart replacement therapy achieved. Like, make it clear, this is not an experiment. This is a real good option of living. No, it's a tough one. Dr. Haythe, I know that you have so many patients receiving advanced heart failure, so many young women.
Well, I will say that I have some patients, I think that when you think about an LVAD, it can be a tough pill to swallow, right? It seems like cumbersome, and you have these batteries, and the patient's like never going to swim in a swimming pool again, and blah, 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 all these things that seem terrible. But interestingly, and even I at times would think to myself, is this something I would want for myself? But then I've actually seen a number of patients who, let's say they aged out of transplant, or, they had some reason they couldn't be transplanted at the time, get an LVAD and really have this incredible, like, golden years of life that was almost taken away from them. They're like 70s and early 80s. I've had patients who send me videos of themselves playing golf with their LVAD, and they're in Florida and they're retiring. So that's incredible. And then, I've seen women who have transplants who want to have a baby, and we help them get through that and have a baby with a transplanted heart. And we see, people who have been transplanted, and I think for me, when I was first in my training and I saw the experience of, going with the plane to go pick up the heart and seeing the family of the donor and what this incredible gift that they've decided to give, and how that donor is and their family is treated with the utmost respect, and then to bring that heart back and give it to the patient who's really dying and waiting for life, and have their family receive this incredible gift of joy and life, is like an experience like no other. And then to see those people come back, even if they have a great hospital course, even if they have a tricky hospital course, it's kind of amazing how much people can rehabilitate, and just their cheeks go from being gray to pink, within a few days of getting a heart transplant. So those were the kinds of things that really moved me and make me enjoy doing this as a profession.
Thank you.
To echo what Jen said, there's a number of people that I've seen in their older years of life who are quite sick, and while they're hesitant to get an LVAD, they ultimately do, and it really has bought them, those few golden years to really see their grandchild, or meet their grandchild for the first time, or see their son or daughter graduate from college, and it certainly can be very, very rewarding.
So Dr. Bhatt, I'm going to pin a little bit with you, if you don't mind, because we have a lot of questions that is coming on the questionnaire, and I want to link it, and we can talk hours and hours about the beauty of advanced heart failure. But the goal of us is to let people live with their own heart. And it seems to be that still there is some confusion. Like today, we have like this very clear mission with people that have a reduced ejection fraction. And maybe you can put, because there is question from the audience a little bit, what is the order of thing and what medication you want those patients to get, and make sure they're getting, because we don't want them to get transplant. We want them to be healthy with the heart failure.
Yeah, absolutely. So we know that there are some pillars of guideline-directed medical therapy that we know at target doses of medications have been proven to help reverse adverse remodeling and help patients feel better and live longer, and certainly also help patients recover their ejection fractions and heart failure with reduced EF. So the medications that we reach for in these situations are the class of beta blockers, and now Entresto, and SGLT2 inhibitors, and mineralocorticoid antagonists like spironolactone or eplerenone. And our goal for these patients when we see them in the office is to really get them on target doses of these medications as quick as possible, and at the doses that they tolerate the best. And what we've really seen is that it makes patients feel better and live longer, and oftentimes help their EF recover. And so that's really the pillars of management of heart failure before we even get to the advanced stages.
So I want to help here because we have one of the questions from the audience that said, Entresto, I have a patient that is stable on ACE inhibitor ARB. Should I still move them to Entresto?
Yeah, so we know that the new guidelines say that first-line therapy for patients with heart failure with reduced ejection fraction should actually be Entresto unless there's an absolute contraindication. And we know that Entresto actually reduces heart failure mortality and reduces heart failure hospitalization. So Entresto should really be the first-line treatment that we should reach for. And even if they've been on a stable dose of an ACE inhibitor or an ARB, we really should be looking to transition them.
Yeah, and I think it's becoming a little bit complicated because we have those four pillars, Entresto, SGLT2, Farxiga, or Jardiance, beta blocker, and mineralocorticoid, but we have more now. We have the Versigua, we have omecamtiv. How do we choose? Because this is the time to send to a heart failure to specialist to give you the special cocktail, and then maybe after that, the patient can share care and managed by general cardiology?
Absolutely. So I think that, all of us in the care of these heart failure patients, primary care doctors, cardiologists, heart failure cardiologists, it's all of our responsibilities to titrate and start these medications. There is, certain nuances, and if you do run into difficulty with titrating these medications, that's really where your heart failure doctor can come into play here, and especially with some of the newer therapies, to see what a patient could be a candidate for. I think one thing also to remember about heart failure patients is that they are on a lot of medications. And so we want to make sure that we're offering them the medications that will give them the most benefit. And then also are cost effective for them as well, because we know that a lot of these medications can be very pricey or not insurance covered. And so we really want to make sure that we're putting medications on in the right order and are actually beneficial for the patients.
Yeah. But not all patients are heart failure with reduced ejection fraction. So Dr. Clerkin, maybe you can help us a little bit. Some of them, even almost half of them, have normal ejection fraction. What can we offer those today, or are we still in a limbo?
Good question. And so a lot of recent research has demonstrated that there what we classically would call diastolic heart failure, or heart failure with preserved ejection fraction. There's a bit of a spectrum. So the patients who truly fit that bill are the ones that really have normal ejection fractions, that their ejection fraction is 60% or above. And those patients, with guidelines, there aren't many therapies. But just last August, the Emperor Preserved trial with empagliflozin and Jardiance has demonstrated ability to reduce hospitalizations in this group, in this very tough to treat group. So that's an additional therapy in that group. And then similarly, there are a number of trials that are going on. One which we're enrolling in is the Rebalance trial, where it involves unilateral splanchnic nerve denervation to redistribute the stress volume in the body. And it's been demonstrated to significantly reduce cardiac filling pressures and improve symptoms in the early stage trials. And so now it's undergoing the randomized pivotal trial. So that's showing a lot of promise as well. And then similarly, what has been recently shown is the subgroup that have a kind of normal to mildly reduced people with an ejection fraction of 40 to 50%. And in the trials with SGLT2 inhibitors, with sacubitril, valsartan, or Entresto, it's been demonstrated that there's a gradient effect that among people whose ejection fractions are less than 50% or even less than 60%, they still have a benefit from these medications above what the true HFpEF, or people who have the ejection fractions above 60%. So there's still a lot of things we can do. While we don't have as many therapies as proven therapies for individuals with high ejection fractions and symptoms of heart failure as we do with low, there's still a lot to do, and there's a lot in the pipeline. So there's plenty we can offer these patients.
But Dr. Clerkin, you took me to a little bit different direction. You said something that maybe we need to discuss it a little bit. When you send a patient to one of you, maybe there is the FDA approved medication, but maybe you can offer them something else. Like you mentioned, the Rebalance standard, the splanchnic denervation. Dr. Kuras, you spoke about cardiogenic shock. We have a lot of experimental devices that may help save people. This is maybe something that is a reason to send a patient to referral, because if we know that they have a disease. So Dr. Kuras, maybe you want to speak a little bit about the research opportunity that can give patient a medication that they will not give otherwise.
Yeah, I mean, I think that is an important reason to send, and I do definitely get referrals for patients that are, on excellent guideline-directed medical therapies for either HFrEF or HFpEF, but the patient's still not feeling well, and they want to explore other options, or their physician wants to explore other options. So we do have several different types of clinical trials available at NewYork-Presbyterian. Some of them are medication-based trials, some are device-based trials, and some are procedural-based trials. So in terms of things for heart failure with reduced ejection fraction, in conjunction with our cardiac surgery and interventional cardiology colleagues, there are a couple of different trials going on right now, looking, for instance, in patients with ischemic cardiomyopathy that we could do LV reduction therapy on them, meaning sort of do a less invasive version of cutting out the scar in the LV. So getting rid of that LV aneurysm to then make the heart pump more efficiently for the patient. And so this is a approach that's done both percutaneously and through a little mini thoracotomy incision. And so that is one example of a procedural based therapy. There's also another clinical trial where we again are trying to remodel how the LV looks. And so the interventional cardiologists again are threading a semicircular device inside the LV and cinching the LV together to try and again improve the LV geometry, which will then improve the LV hemodynamics. And so these are two examples of procedural type of clinical trials that a patient who's not necessarily responding to medical therapy in the way that they would want to be, that we could offer at NewYork-Presbyterian.
And Dr. Karas, I think the hour is too short to mention, but I think in almost every condition, we have at least 2 or 3 studies, if not 10, that run in, like cardiac amyloid, pulmonary hypertension, HFpEF, HFrEF, medical studies, device-related studies. So definitely a lot of approaches that definitely we need to address. So another question from the audience that I'm opening to whoever wants to take it, and it's actually a very, very relevant question. COVID and heart failure. So let's break the question into 2. First of all, what happened to a heart failure patient when they get COVID? And second, can COVID cause heart failure? So maybe just choose whoever wants to take it. And Kevin, I see you lean forward. You want to take the first one?
Sure. So, I mean, we saw this with the most current wave with the Omicron variant, that COVID clearly exacerbates heart failure, that a lot of the patients we saw coming in were not necessarily as symptomatic from COVID as we saw last spring or even last winter, but they were exacerbating their chronic conditions. So we saw a lot of heart failure exacerbations in individuals with COVID. So it definitely can impact in that way. And as we know from the early data and the data that persists, our patients are at much higher risk, which really puts the importance on really trying to make sure that they understand to get vaccinated. And now that we have potentially outpatient treatment therapies, whether it's a 5-day course of remdesivir or sotrovimab with monoclonal antibodies or Paxlovid with the pills, we do have options that we can put for give to these high risk individuals. For the second question, can COVID cause heart failure? In some of the long COVID patients you're seeing, yes. The thing that begs the question is it unveiling a pre-existing stage B heart failure where they had systolic dysfunction but weren't asymptomatic? There's a lot of concern early on that there might be a lot of myocarditis or direct myocardial invasion. Some MRI studies have shown that while there are changes, they weren't so drastic. And there's been very, very rare, I think there have been a couple of case reports of actually COVID been seen on endomyocardial biopsies. So it definitely can, like any significant illness, can lead to a decrement in systolic function. But it's not, at least seemingly at this point, we seem to learn something new every day or every couple of weeks with COVID, but leading to a new pandemic of heart failure, but potentially unmasking and exacerbating pre-existing heart failure.
No, definitely. And Dr. Bhatt, Dr. Bhatt is actually practicing both in Weill Cornell Medicine and in NYP Queens. You've seen a lot of heart failure patients get COVID. There was a big surge of COVID in the Queens area. Tell us a little bit from your experience about that.
Sure. So I think just to highlight what Kevin said is that, it's unclear if COVID is related to de novo cardiovascular disease, or it's really unmasking patients that are predisposed already or have asymptomatic disease. But it's very clear that these patients are coming in 30 days 3 months, 6 months out from a COVID infection, decompensated with either acute coronary syndromes or decompensated heart failure or exacerbations of heart failure in patients who have existing heart disease. And we're actually seeing these patients become quite sick, sick enough that they have kind of progressed from the stage B to C heart failure to stage D heart failure kind of more rapidly. We're also seeing this in much younger patients as well. Certainly, so it's something to be vigilant about and to really monitor these patients who are getting COVID through.
Mm-hmm. Thank you. So again, there is a lot of questions coming in, and we will be challenged to answer all of them. But Dr. Haythe, maybe you can help us with this. You mentioned the word Takotsubo. That is always a word that will create a lot of attention. And the question is, what is the latest approach to Takotsubo cardiomyopathy? Is any sex differences? And I think you alluded to that and maybe emphasize a little bit about it.
Yeah, so we certainly will treat Takotsubo like any other heart failure syndrome, and they actually have incredibly good outcomes with most people recovering, although there is a risk of recurrence in people who've already had one episode of a stress cardiomyopathy. It's definitely more prevalent in women than men. In women, more commonly triggered by an emotional stressor, whereas in men, more typically a physical stressor. But again, we would treat our patients with beta blockers, Entresto, diuretics as necessary, follow their echoes over time to watch for improvement in their ejection fraction, and then, monitor those symptoms closely. Usually these patients come in typically appearing like they're having an MI, right? So they have chest pain, they have EKG changes, they get taken to the cath lab, which demonstrates that they don't have an acute MI and that this is actually a Takotsubo type picture. So but it is important to remember that those people could develop coronary disease over time, right? So they're not always going to never have coronary disease. So that's another thing that we find is important to watch in these people.
Thank you. So again, there was one more question, and Dr. Kras, maybe you can help it with this question. We didn't touch at all about the intercept between heart failure and electrophysiology and the devices associated with it. What's going on right now, and what kind of patient we are looking, and what can we offer them?
Sure. So I think, most providers, when they think about, what are the electrical things we need to worry about in heart failure patients, ICDs come to mind, defibrillators. And most people are familiar with the fact that patients with ejection fractions less than 35% are at higher risk for sudden death and arrhythmias and should be considered for an ICD. I think where sometimes we don't identify patients as readily are those that are candidates for cardiac resynchronization therapy. And those are patients who have a bundle branch block on their EKG, and they may actually benefit in terms of improvement of their ejection fraction, improvement of their symptoms, and reduction in heart failure hospitalizations. But then there's also heart failure patients are obviously at risk for developing all different types of arrhythmias. And so, we work very closely with our EP colleagues to help control atrial arrhythmias, whether that's through medical treatments, ablation procedures. Ventricular arrhythmias, again, can be addressed in similar fashion. But then, Reema had also alluded to the newer devices also having other monitoring capabilities. So for instance, if we have a patient that is going to need a ICD or a CRTD device, then we may choose one that has these remote monitoring capabilities. And this way we could then follow the patient from their home and be able to know when they're starting to show signs that an exacerbation may be coming.
Yeah, and a patient, we talk a lot about ICD, but some patients come to me lately and show me a lot of advertising to a lot of new technology that are coming into heart failure and EP together. So maybe we can speak a little bit about cardiac contractility modulator, many Bauer receptor stimulation. And Kevin, do you start practicing those in your clinic? Where do you see them fitting in, and which patient we want those referral to send to us with those?
The most exciting thing with the cardiac contractility modulation is the kind of the new device they've come out with, because up until this point, there's a fairly narrow window of patients who are candidates. You know, it's been studied in patients with an EF of 20 to 40%. The challenge is that with the leads from the device, and many of these patients require an ICD, you really start worrying about having too much in the patient and developing stenoses. They've developed a new device that incorporates a defibrillator. And I think that's really an exciting technology with the trials, getting underway, to see that that incorporated with a defibrillator, you're not worried about excessive leads in the body. And it's something that did demonstrate in the trial that improved a functional class, a New York Heart Association functional class among individuals. And in terms of the cardiopulmonary exercise test, increased their peak VO2 by 1. So it's something that is something that is an exciting addition on top of the medical therapy that we discussed, especially in the new iteration of the device.
Definitely, I think it's important just to whoever doesn't know the technology, contractility modulator. It's a type of a pacemaker that it actually gives impulse in the refractory period. And by doing that, actually generate an impulse of calcium into the cell and generate improvement in the circuit gene and the way that the calcium is being handled inside the cell and improve the contractility and inotropic. As Dr. Clerkin mentioned, it was studies in the low ejection fraction group, but right now, and it's already been approved in this group, but right now, it's been studied also in the normal ejection fractions. There is a study called M-Higher, but again, in NYP, we're part of them, but looking for those patients and trying to understand whether or not we can give them cardiac contractility modulator. So as we heard today, we can speak about a lot of technology and things that will make patient feel better. Our main goal is that patient will be with their loved one and do their life as they want to live their life, with a good quality of life, with their own heart. But when extremists come, we'll not shy away from him. If it's a pregnant woman or a cardiogenic shock patient, and if for God's sake we cannot save their heart, we still can save their life and offer them advanced heart rate therapy. So I want to thank everybody here. First of all, this amazing panel, that beyond being a panel, amazing doctors, each one of them, I know them very personally, and I know those are the physicians that you want to take care of yourself and your family and your loved one, because they're so passionate about it. And I'm sure that if there will be more questions, we can answer them. So Elizabeth, I will pass it back to you, and thank you for hosting us here.
Thank you so very much. I could see from the chats, people are really moved by all this information and how valuable it is. We are going to share contact information. You'll get an email with all of that information, so you'll be able to contact the doctors and be able to take next steps. But thank you all for your precious time. We truly appreciate it. Thank you so much to our attendees for spending some of this afternoon with us. As I mentioned earlier, this has been recorded, and we will share the recording with you so that you can watch it again and share it with others as well, as we hope that you will do that. So again, thank you, everyone. Thank you to this incredible panel. And I wish you all to stay safe, stay healthy, and we'll look forward to seeing you on a future webinar. Have a great day.
I have to say one thing here that I think is so funny is that in the midst of this meeting, I just literally had one of my transplant patients, but I can't show or reveal because of HIPAA, but text me a photograph of herself with her son and her grandchild all together. And she was transplanted in the last 6 months, and she looks beautiful and amazing and healthy, and she's with her grandchild. So I think it's kind of funny that came to me right while we were all talking about this. Anyway.
This is life. This is real.
Real wonderful testament to what you all do and what can be done. So thank you so much for that. Have a great day, everyone. Bye-bye.